Welcome to the Java Cafe, Java fam. Good morning. Welcome to the Java Cafe, Java fam.
Good morning, everybody. Good morning. As you can tell, today is a Tuesday, January 7th, 2022. I'm back on my track and getting the date right. It is the 15th. Oh, I should have Dr. Labrie in to help me. I believe it's the 15th episode of Your Healthy Java, and in celebration and acknowledgement of Father's Day, we are discussing men's health today. We have two esteemed guests with us that's going to talk with us. First, Dr. Labrie is going to share some things about routine and preventive health care when it comes to men, some of the gaps we've talked often about inequities in healthcare. But today is a special episode, and it's not just for men. So ladies, and we also acknowledge the fact that we are talking generally about cis men that identify as men, and we understand that, and we've talked on this platform before about men with trans experience, but today we are talking generally about cis men, and so we just wanted to name and acknowledge that. And I wanted to bring in Dr. Labrie, my co-host and medical director first. Good to see you this morning, sir.
Good morning, Jimmy.
Let's just say that I had an inkling this morning not to wear the hoodie. When I saw my guests come in and everybody's in, well, you'll see in a few minutes. So I'm sorry. Look, I thought this blue was sort of MGH blue, but when I got on camera, I'm like, maybe not so much.
It's close enough.
Okay, thank you, sir.
It's a medical blue.
Hey, good morning, sir. Greet the people. Let's give a little context as to why we're talking men's health today. And if you would like, it's up to you. We can bring our guest on now or after you share sort of a little bit of the stats.
Yeah, sure. I mean, either way, it's a good morning, everyone. Good morning. It's happy to be back. And yeah, we've discussed this in our sort of planning meetings about having this little acknowledgement about men's health in honor of Father's Day coming up this Sunday, I think. I don't plan my own Father's Day.
No, it's the 19th. You're going to get in trouble.
Oh, okay. Well, I don't. It's this month, okay? It's every day of the year.
That part.
Exactly. But seriously, though, we do know that there are some healthcare gaps between men and women. And I know you've mentioned initially that we're talking primarily cis men, so testosterone and a few other distinguishing factors. And we want to obviously bring that to everyone's attention and see what we can do to help reduce that gap between men and women when it comes to health. And we have some stats we'll share. And then we'll segue into something a little bit more specific. Today is primarily about prostate cancer. We will obviously be taking questions, and we can entertain some of the non-prostate cancer questions as we can, or we'll get back to you as we usually do. But we'll have a little bit more of a focus. So why don't you bring in the guests, and we'll start with the general.
Absolutely. And I just want to say that one of our guests, I had the opportunity to meet him a few months ago. I believe Charlotte James from Greater Love Tabernacle is on, and they did a men's Zoom, and I had the pleasure of hosting that and met Dr. Lee, and I'm looking forward to hearing more from Dr. Crawford as well. So why don't we have you guys introduce yourself, and then just Dr. Lee, I'm mad at you with the wonderful bow tie with the Ether Dome background, and we'll explain that relevance later. But why don't we start with Dr. Crawford? Please introduce yourself. And after the introduction, if you could give us one word to describe men's health from your experience, and then we'll go to Dr. Lee.
Jimmy, thank you. I just want to thank you and the audience and for allowing me this opportunity to be on the program. I'm Director of Clinical Trials and Education at Prostate Health Education Network. Prostate Health Education Network was founded about 18 years ago by a prostate cancer survivor, Mr. Thomas Farrington, who was diagnosed, who's a 22-year survivor from prostate cancer. And just like everything starts in Boston, Finn started in Boston.
Okay.
We're Boston based. There was, did you want one word?
One word for now, and we'll get context from you later. This is sort of a practice we do in a Java Cafe, and it may be interesting, but if you could put it in one word based on everything that's going on and what you're seeing in trans and men.
Disparity.
Okay, and Rick shook his head. Rick, I'm so sorry, Dr. Lee. Dr. Lee is we built this rapport on Twitter and that day on Zoom. So if I slip into Rick here and there, please forgive me. But Dr. Lee, with your wonderful bow tie, with your Ether Dome background, please introduce yourself and give us one word as well. And in the introduction, tell us a little bit about what you do.
Terrific. Thank you so much for the invitation. Of course, we've been talking about bringing this onto the show for a while, so I'm really thrilled to do it. My name is Rick Lee. Calling me Rick is totally fine. Dr. Leo is my mother, but I'm a medical oncologist at Mass General, which means that I give systemic or whole body therapies for cancer, and my focus is on genitourinary cancer. So that includes prostate, kidney, bladder, testicular cancers. That's my narrower focus, in which those are the patients that I see and the research that I do. Part of what we also do at MGH is we have a diversity and equity council within the cancer center. So I'm a member there. And so we are, working to try to think about and fix the key word that Dr. Crawford brought up, which is disparity. So we have a real passion for that. And that's how I wound up on a show with James earlier this year. I'm going to go with my one word as being access.
Yes. I'm looking forward to this conversation. Dr. Labrie, I think there's going to be a moment at some point today. But Dr. Labrie, are we ready to just go over some of the stats in general?
Sure, why don't we do that? Because we've mentioned it in
Absolutely.
the show. So yeah, I mean, we've mentioned there is a healthcare gap in men and women in America. And this is where we'll focus. This is data from the National Center for Health Sciences. And sadly, we're seeing a trend that is not the most wanted trend, where the gap is actually widening a bit. And this is data from the 1990s, not 1990s, 1900s, sorry, where the health gap in life expectancy was about 2 years from females and males. And as of 2017, it went up to 5 years, where females are expected to live on average about 80.1 years, and male is 76.1 years. So that's the 5-year gap in life expectancy that we're seeing. So this is sort of the raw data. There's obviously a lot to it, and we won't be able to get into all of it. And I will go to the second point we made. So this is the disparity, and then we'll talk about the access part. And let's go to the next slide, please.
Absolutely. Okay, there we go.
There we go. So these are some of the factors that is sort of causing this gap we're seeing in life expectancy. Again, there's probably more to this. This is sort of overall the sort of the highest factors. And the one we'd like to focus on a little bit is the lack of routine medical care. That's at the bottom. So that's the access part. And not just access in terms of having access, but also there's a cultural, behavioral aspect to this as well, where men may not seek care, routine care as much for a number of reasons. And so as we've done for the past 7 months, 8 months or so here, we talk about getting people back to care. This has been sort of the underlying, the basic sort of foundation is how do we get everyone to care, get a primary care doctor, have access to the care that you need. And when we look at this here, we realize there are some of those factors we may not be able to change and modify, at least not with modern sciences at this point, when it comes to sort of sex hormones, and reproductive anatomy and whatnot. So you can argue that these may be out of someone's control, but the lack of exercise, the diet part, the behavioral things, you know, alcohol abuse, smoking, these may be in someone's control. And we'd like to at least bring awareness to these factors so that we can hopefully start to modify and tackle these issues. And so, as I said earlier, we won't get into all these. And so today we'll be primarily focused on prostate cancer, and hopefully everyone is able to get to the care part and hear more about prostate cancer from their doctors directly, but we will do our best to address the more general aspect of that today.
Absolutely. Dr. Crawford, let's jump right in as far as your words. And in there, you can share whatever information about your practice. And as Dr. Alabri said, we're talking mainly about prostate cancer today, but anything that comes up on the list that Dr. Alabri shared, or just what you want to share, please feel free to do so. So your one word, Dr. Crawford, was disparity.
Right.
Can you give us some context as to why you said disparity?
Well, if I said 1 in 5 Black men in their lifetime will have prostate cancer. Okay. The largest racial disparity of any major cancer is prostate cancer. When you hear prostate cancer, you hear prostate cancer in the context of all of America.
Yep.
But just like politics is local, healthcare is local.
There's a saying that Dr. Alabri has that healthcare matters. Get it where you can.
Right.
So when you say local, what go a little bit deeper there?
What I mean by that is when you separate and go into the community and look at it at the community level or even at the county level, depending on what state you are, you'll see significant disparities. And that disparity means per 100,000. If I say that the incidence of prostate cancer in Black men in the United States, it's upwards to 70% above white men, higher, the death rate is twice that of white men. But that's at the state level. Now, we know you don't have Black folks in every single state in the United States. So let's just bring that down to about 35 states that 99% of Black people live in. So you start to change the numbers. Now you go to a county level or a state level and you'll find the incidence is higher. 100% higher, not 70% higher. Death rate 2 to 3 times higher. We had the president of the United States, and this is said respectfully, came to Boston, talked about the Moonshot Initiative, and said nothing about prostate cancer. Breast, ovarian, colorectal, lung. So access and knowledge and awareness are key, but if we don't even start at the leadership, it impacts Black men. What you won't find is this is statistics that I pulled out. And these statistics are the American Cancer Society give predictions of the incidence of cancer. And let's look at the top 4 cancers: prostate, breast, lung, colorectal. Those cancers were predicted to increase no more than 4% between 2019 and 2022. Prostate cancer for all men in the United States had a significant jump, 54% increase. Now they have changed how they predict prostate cancer, but over that 4-year period, there is a significant increase that wasn't identified or brought to the attention. Now you recognize that that when the general population sneezes, we get COVID.
Dr. Crawford, there's so much to unpack there, and I think this is a good segue into Dr. Lee as far as access. But one of the I'm curious, and we can come back to this, if the predictions were done pre-COVID And then with all that these were done in COVID. Okay.
And see, let me be clear.
Yes.
Those predictions do not reflect the 10 to 15% increase related to lack of access, lack of treatment.
In a time where screenings and regular appointments couldn't be done. Dr. Lee, I know you've been patiently waiting, and this is an area that all of you, but I've seen you present here before, and so I know we've been waiting to get you in. Your word, Dr. Lee, was access. And then based on what Dr. Crawford said, why did you, not based on that, but in addition to what Dr. Crawford said, why was access your word?
So it's kind of nice that Dr. Crawford and I get to keep interfacing with each other because our words are so complementary. And, access is, I think, the way to upend disparity. And I would say that for a few reasons. So as Dr. Crawford has, very thoughtfully described, prostate cancer is higher in Black patients, Black men. And what we see from a couple of different studies, just to pull these things out. So you can look at the higher rate of prostate cancer mortality in Black patients and wonder, is it a difference in biology? Is it a difference in how they respond to treatments? Or is it a difference in access to care? Well, lots of folks have done very expensive studies looking at prostate cancer patients from a variety of different racial, ethnic groups, and maybe there's some differences. When you look at these groups in terms of what are the genes that are turned off, are on, or mutated. Maybe there are some differences there. Very expensive studies to show this. Is there a difference in response to treatment? And if we look at the more advanced prostate cancer treatments, meaning for metastatic disease, looking at things like Provenge or Sipuleucel T, which is a vaccine, looking at responses to these androgen receptor targeted therapies that are in very common use. Actually, Black patients respond seemingly a little bit better than white patients. So it's not a matter of not responding to therapy.
That's right.
It's unclear if it's a difference in biology, but it's not necessarily clearly a difference in response to therapy. Instead, if we look at access, so I'll point to two different sorts of studies. There's one study that looked at autopsies of men who died of other causes, men who died of trauma, et cetera, where they had their prostates examined, they sectioned through them and just looked for cancer. These are men from their 20s through their 80s. And they showed that in Black and white men in their 30s, that percentage was something like 31%. Both Black and white men, very similar percentages, had cancer found in their prostates, even in their 30s. Now, they weren't going to be diagnosed with that. That's not how they died. But when you look at it, the cancer rates were very similar when those men were examined at the time of autopsy. What does that tell me? It tells me this is a common problem, grows very slowly over time, and that if you look at those incidence rates, looking at Black and white men, very, very similar. And this is commonly done, or this has been done in other countries as well, showing that prostate cancer starts early. But I thought what was interesting there is that the Black and white men had very similar percentages at all these different age categories, which tells me that the incidence rates may be similar, but why are they being diagnosed at later stages, perhaps, and therefore not at the most curable stages? I'm going to point to one other study that was recently described at the VA, where the VA, they looked at Black vets, and they showed that that Black vets who were diagnosed with prostate cancer as compared to the white vets diagnosed with prostate cancer had all the reason to believe, based on social determinants of health, that the Black vets were going to have worse outcomes. They had, higher PSA, less education, lower income. And yet, when they looked at those patients within the VA system, they actually had better outcomes, better, lower rates of high-risk pathology, lower rates of metastatic disease, and better outcomes. So what does that tell me? It tells me that if you're in a system like the VA, which is taking care of their veterans, if you're in a system that's closed where everyone has access to medical care, that actually the biology, the disparities, I'm not going to say they go away, but they can be upended. And that's the reason why I would say it's the access to care that becomes so important. And can I just make one other comment?
Go ahead.
because you started the show talking about cis men, and I'm just going to put a plug out there to say
that's what I was going to do too.
Yeah, that I certainly I've treated patients who are transgender with a variety of diseases, including prostate cancer. So transgender women with prostate cancer. This is a group of folks that we have to ensure that we still have the appropriate types of screening and care. Obviously respecting the gender, but understanding that the biology, that the cancer susceptibility remains, and that prostate cancer screening should still be something that we think about when we're giving equitable care for transgender folks.
That's exactly right.
And if Dr. Crawford, I'm going to come to you. Usually I try to keep it balanced. I was going to go to Dr. Alabre, but I see you getting ready to hop there. But one of the things I want to name based on what Dr. Lee just said was, with everything that you just named about access and inequities, if you're a trans man or a trans woman, that access and equity around care, there's extra. Don't be a trans woman or trans man of color. Then there's a whole nother. Dr. Crawford, I saw you agreeing and shaking your head. Yes. Your response to what Dr. Lee said.
Well, that was the one question that I had when you were talking about cis men, is that trans women have to be incorporated, because we look at phenotypically what you look like on the outside.
Hold on. Tell us here. Phenotypically.
So we talk about phenotype is what you look like on the outside. Okay. And then genetically is what your genetic makeup is. And so just because you may look a certain way on the outside, everything boils down to what your genetic makeup is.
And that's not a judgment statement. That is just fact of medical science, right?
Right. And that's why it's so important, because, and this is something that's very interesting when I throw this out there. And there is the issue when it comes to access. If early detection of prostate cancer, the lifetime expectancy is greater than 90%. This is data from the CDC. If you detect it early and locally, in the military, in the Veterans Hospital, they're screening early. And the problem that we've had, and a major problem, was the discussion about prostate cancer and screening for prostate cancer for Black men or high-risk men should begin at age 40.
So wait. I'm 50. So I'm contemplating now. I'm like, okay, I got to make my, make my point.
40.
So
40.
So
you're a decade behind.
Dr. Crawford, don't say. So Dr. Alabre, this is a good segue to you for Dr. Crawford before I get in trouble. Now, I'm going to pinch myself. Keeping up with routine and preventative care, that is one of the number one way. Presumably, that is a good way around access. We're talking about screenings and early detection. Dr. Alabre, from a routine and preventative care standpoint, let's talk specifically to Black and brown men. How important is routine and preventative care? Because most of these are done from a referral, typically off of physical, can I presume?
Not exactly. So the screening part is typically done in the primary care office. Referrals happen mostly after diagnosis or when suspicion starts to get a little bit high that they may be. So there are different levels of comfort, but generally most of the routine care, prevention, and screening is done by general internists, and then they refer when needed. It's funny because that's what I actually written to go back to on my paper there. So one thing I wanted to mention before the screening part is that the complexity, I guess, of cis versus transgender women who have sort of genetically male organs, prostate specifically today, about the culture and societal factors, and also education personally, because I have dealt with a couple, not a lot, but trans people who actually have a lot of discomfort bringing these issues up to their doctors, to their providers. And so having the education be done both on the side of the patient and providers so that everyone feel that they are welcome. They are understood and appreciated and cared for equally, equitably is a huge factor. I don't want to get into that too much, but I really think that getting the word out there so that people who may think that they don't need these types of screenings anymore realize that actually it still matters and they do need it, and they can find that care. It is there, even if they've had maybe bad experiences, but there are places where we are more than willing to take care of anyone who needs, however that is. So the second point was in terms of screening. Part of the issue with screening and when to start is really not patient's fault. I think there's been a lot of confusion.
Hold on for 1 second, because I got Uncle Java in here that Dr. Crawford just informed me, because I thought 50 was, and so thank you for that point. In all seriousness, Thaddeus, that they used to say 50. Am I right?
Well, so that's what I was going to get into, because there's been a lot of different reports and controversies in the sense and disagreements even, and some very strong in terms of whether to start screening Black men earlier than white men. And if you look at the sort of U.S. Preventive Task Force, which is the sort of body of physicians and health providers who review data and make recommendations for screening, some of these views and recommendations sometimes vary from what the Urology Society mentions and what the Cancer Society mentions, which has created a lot of confusions for not only patients, obviously doctors as well, who are advising and bringing these up. And so it gets really confusing as to what to do. And like you said, Jim, that you thought it was 50, and a lot of people do feel that way, and that's what they're being told by their doctors. And so this is a good place to actually some clarifications to this, and sort of maybe we can talk about where the data is coming from and what really is the recommendation. I'll kick it back to Dr. Crawford there.
Dr. Crawford and Dr. Lee.
Because I put together, if you go to finpsa.com, we already broke down the categories of each American Cancer Society, American Urological Society, NCCN, which is the premier. So organization, National Comprehensive Cancer Network, and the United States Task Force, Preventive Medicine Task Force. The Preventive Medicine Task Force acknowledges that screening for prostate cancer should begin at age 50. But in the footnote, in the small print,
if you're not an academic, you're not going to look at the footnote. First of all, you're going to look at the reports.
Black men are known to be at high risk, and men with high risk may need to start discussions earlier. So they don't even, the National Comprehensive Cancer Network comes out hard and says, boom, age 40, begin those discussions. High risk, Ashkenazi Jews, Black men, men with family history, genetics, all that is there. National Comprehensive Network, then American Urological Association follows up. The problem is that United States Task Force dropped that bomb about 8 to 10 years ago. And when we talk about family practice, primary care, that information becomes given to the clinicians. And then it takes time to change that, what was policy before.
The protocols and the ruling out and procedures and all the screenings and
And so we can point the finger and, but at the end of the day, that's why we're on with you.
Yes,
That's why we work every day to make sure that every man who is at high risk understands you need to start screening early.
And let's just also add, based on what you all just said, educated us about, though a trans woman or a trans woman, it's genetically this. And I learned something today. We're in Pride Month, and I kind of heard a little bit of language from you that, sometimes when people fully transition, this may not even be a factor, genetically speaking. And so there's just so much. Dr. Lee, you've been patient. And I know there's so much you want to jump in on based on what was just said. Sir, your reaction to what we just shared in the past few moments.
Well, yeah, I brought up the transgender comments also because I do think it's a really important part of what we do, albeit a small fraction of patients, but you know, in line with the idea of equity, in line with the idea of Pride Month, and you know, these are patients that we see, and that we need to, you know, bear this in mind. And even for patients who've had, you know, gender reaffirming surgeries, you know, they don't always have prostates removed necessarily, and so we must bear in mind what is the sort of care that a transgender woman has received, and you know, does the original organ still there? And these are things we got to pay attention to.
Even remnants of the original.
Even remnants, right?
Right.
So then to think about the prostate cancer screening, I mean, what we've seen over time is that when the U.S. Preventative Services Task Force recommendation went down to a D back in 2012, in the ensuing years, you know, with less screening, and we can be cynical about it and just say that was, you know, cover for not needing to screen anymore, but with less screening, you know, we've encountered higher grade cancers when they've been detected.
Right.
Perhaps not surprisingly, when you stop screening, you won't find them. And then when they're allowed to grow, they can become, you know, bigger problems down the road. So I'm a believer in screening, but I rely on my colleagues like Dr. Alabre, because as a medical oncologist, I'm seeing the folks who are already diagnosed. But people ask all the time about when screening should happen.
And I mean, we have that right here. Dr. Lee, thank you for messaging me too. And so Dr. Crawford or Dr. Lee, if you just wanted to go through here, and this is what you really spelled out. So this is the resource, everyone, where you're able to go and get with Dr. Crawford. I'm sorry. Let me see if I can fix this here. That's a little bit better. I mean, the information's a little blocked, but
because
what our heads.
Yes, what we did here was, you know, people say, oh, you can download the app. I said, forget the app. You can go online, finpsa.com, pull it up on the phone, sit elbow to elbow with your primary care doctor and say, here are the guidelines that exist. If we're now asking patients to play a greater role in their care, we have to give them reliable information. So you'll see American Cancer Society, that's age 50 for average risk. But you're a Black man and 40 at high risk. But that's American Cancer Society. If you drop down, American Urological Society, 40 at high risk, African American men should speak to their doctor. Drop down to NCCN guidelines. The NCCN guidelines come from the clinic, from representatives from the top 26 academic institutions around the country that set the guidelines that clinicians will use to treat patients. And so they have clearly, there's no question, it's not in the footnote, it's clearly states it. And so there's United Preventive Medicine Task Force. And again, I'm not saying that they don't say it, but they are not as firm as the AUA and NCCN.
Got you. We take questions here, and there are, Dr. Labre, today there are a lot of questions from insurance to testing. And so if there is anything, we're not wrapping up now, but is there, before we start taking questions, I'll start with Dr. Lee, then we'll go to Dr. Crawford. Is there anything you want to leave imparting before we start asking questions? Because one of the things I want you to maybe cover is that even with a screening and diagnosis, it's not necessarily, and let's just say a disclaimer, none of these doctors have examined anyone. They're giving general information from their experience, but a diagnosis early on, what we learned today, doesn't necessarily mean it's a sentence, quote unquote, to death, that there are treatment options. And so can you just speak a little bit to how important it is for the early screening and that conversation with your, primary, and then if they do get referred to you after the diagnosis, that's not necessarily a total death sentence.
Right. So I'll go back and emphasize one of those studies that I described to you where men in their 30s were found to have prostate cancer at autopsy when they died of other stuff. What that says is that this disease starts young and it's diagnosed at the age of 50 if you're screened at 50 or 40, but when you're finally diagnosed with it, then the men who come to my clinic are like, how long have I had this? And sometimes I have to tell them it's probably been there for like a long time. And so what we have is a spectrum of prostate cancer where there's low grade and there's high grade. Many folks wind up in the low grade category. And the important thing about the low grade category is that not all low grade prostate cancers need to be cured. Is it curable? Yes. Does it need to be cured? Maybe not. And by stating it that way, those patients may be spared the side effects of therapy, because some men wind up saying, wait a minute, I don't want to get screened because then that's going to lead me to have, problems with impotence, erectile dysfunction related to prostate.
Let's keep it 100, sir. Yes, sir. This is a morning, but let's keep it 100.
All right. But this is family hour, it's medical hour. But that's important, right? Because just being diagnosed does not mean definite treatment and the end of urinary control or erectile function. You go and see experts who can tell you whether or not this needs to be cured based on your level of risk, based on the type of disease you have, maybe based on family history. And that's why it's important to have access to those sorts of services and to have, a trust relationship with both your primary care doctor and the referral system.
There's so many questions here. Would you say, Dr. Labre?
Yeah, sorry. No, I wanted to sort of clarify a couple of points. So we've talked about the start of screening age and whatnot. Let's talk a little bit about how you also screen, because it's an interesting place to be as well as a primary care doctor, and also in terms of talking about access and sort of the disparity in healthcare for men. This is one of those probably most well-known sort of little medical practice people talk about in terms of prostate cancer. A lot of men talk about going to the doctors for their exam, and so everything else that comes with that, every joke under the sun that you can think of.
There's a couple of questions in here about self-examination.
I know. Well, so that's where it gets really interesting, because that is, unfortunately, for some people, one of the barriers to even getting access to going to their doctors. It's really sad that there are people who will say, I'm trying not to go to the doctors, or I don't want to go because of that exam. And so let's talk a little bit about what that screening means and how one should go about it, and whether that should ever keep someone away from their doctors.
Dr. Lee, Dr. Crawford, whoever comes on first.
So this is what I always say. I say that the patients, first of all, you got to get the patients in. But how do we get the patients in? You got to get the family to understand what the problem is here, right? So bringing in loved ones to say, hey, you got to go see the doctor. I want you around. And just having this exam or this PSA blood test, again, does not mean that you're going to require therapy and all the potential complications that go with it.
Do you want to talk about what the exams are, what the screenings are?
And we can answer this, please, at the end of that. If you could answer, we'll start going into questions. If you could answer that, because I thought it was important to put this up as we're talking about screenings and the test.
The point is that what I wanted to get to is that there has to be a re-education of everyone. And right now, we're moving away from digital rectal exam to blood tests. Okay. So men in the community and men need to be aware that the focus is on a blood test, because you can miss with a digital rectal exam.
Now, when you say digital rectal, that's taking a scope of sort.
That's taking your finger.
Your digit. Okay.
Digit.
I hear digital, and and this is okay.
But that's an important point, because you're a layman. You wouldn't know. And somebody said digital rectal exam. It's like, well, they're going to take this big mountain. No, it's basically taking your finger and feeling for irregularities.
as Dr. Lee said, this is a morning and a family show, but let's in all thy getting, get an understanding.
But I wanted to make one point.
Yes.
One point is this: mama, auntie, wife, girlfriend. Women are extremely important in when it talks about the care of Black men. And you brought this up before. And or a loved one. That loved one has the ability to nudge that man to get the exam.
And let's just say we named the sort of typical,
yes,
relationships, but a man to a man and the children.
No, but that's why I preface the loved one.
Yep. Yes.
Because the loved one is responsible for getting the patient to move. Because at the end of the day, hard facts. If diagnosed early, the 5-year survival is close to 100%. Local detection. And the CDC, when you look at their data, above 90% of those detected early, that's local, that's in the prostate, close to 90% survival. And that does not even include all the tools in the prostate cancer treatment tool chest. There's so much that's available. So the point that I have to tell everyone, if you're diagnosed with prostate cancer, you're not dying tomorrow.
And a couple of clarifying points I want to make as well, and say it maybe in layman's terms. The digital exam is not a scope going up. It's actually you. And to Thaddeus' question about doing the self-exam at home and feeling for irregularities. And Dr. Labrie, thank you for mentioning, because growing up, I have heard that, man, I ain't let nobody, so we're going to leave that right there. We have a whole, and I'm going to try to
clarify, Jimmy, a little bit too, of what Dr. Crawford was saying, that if that's a factor, if that's something that's going to keep you out of the doctor's office, it should not. Would you agree? Because we can do the blood test alone. Be, afraid of coming to see their doctors because they might get a rectal exam for their prostate. That is,
and it's already been deployed in telemedicine. There are already groups that were doing early detection screening.
Because you couldn't do the digital exam on Zoom.
Yeah, we don't have a digital rectal exam, if you know what I'm saying. But yeah, in this virtual world, there we go. We've got the access to do a PSA test. I mean, that's what we need.
And there's no recommendation for self-exam out there, just to be clear as well, because you would not know what you're feeling for, what you're looking for. I don't know of anyone who's ever recommended that.
Yeah.
Okay. Thank you for that. I wanted to get into the questions, and the first one is from my mother. She nicely let me know at the bottom. I asked,
you in trouble.
Is prostate cancer the same as testicular cancer?
It's not. They're very different diseases. The prostate is an internal organ. The testicles are an external organ in the scrotum.
Okay.
And very different biologies. Testicular cancer is far less common and yet very curable.
And it's interesting having this conversation with my mother.
I said it. Loved ones. Loved one.
Yeah. I have lots of patients who come in who actually don't quite know where the prostate is and what it is. Maybe we should take 2 seconds and talk about what is the prostate actually. Can
we do that real quick?
Yeah. And if you show the FIN PSA, there's the anatomy is on there also.
Under what tab? Tell me under what tab. We still got it up.
The drop down window, you can just say, what does it look like? Prostate and prostate cancer.
Okay. Y'all go ahead and talk, and I'm gonna find a graphic.
So the prostate's a little organ that sits underneath the bladder. If you think about the bladder, the prostate sits like a little mini donut under the bladder, and through the donut hole goes the urethra. The urethra is the tube that goes out through the penis where urine comes out to drain the bladder. The prostate has a purely reproductive function. It creates the fluid that's part of semen, that's part of reproduction. That is why we have a prostate, why we need the prostate.
And
to get a good visual, a walnut size, about the size of a walnut.
So though we said that, the self-exam, is not the most recommended, if you do employ that or whatever, and if you feel something is bigger than a walnut, is that a good indicator you need to see Dr.
Yeah.
Go ahead.
I'll tell you, most medical students couldn't tell you what a prostate feels like.
Yeah.
So, and that's something we have to teach. So I would just say,
PSA.
Don't make that your screening test, your own personal exam.
And see, what I also wanted to bring to your attention, if you look at the anatomy, the only thing that you can feel when you're feeling the prostate is the posterior or the back portion of the prostate. A lot of Black men have prostate cancer detected in the front portion of the prostate that you most likely wouldn't feel on an exam. And that's why the shift is towards PSA as the primary tool. PSA is a biomarker, a biological marker. It doesn't have to reflect elevated PSAs, prostate surface antigen, prostate specific antigen, doesn't have to reflect cancer, because there's benign states where your PSA is elevated. But what benign, which would be it's non-cancerous states. So I want to put that out there because you don't want everybody scared.
Exactly.
But the point is, the first important thing is, are you at high risk? Are you a Black man? Are you a person that has a family history of prostate cancer? Do you have a genetic risk for prostate cancer? And when we say genetic risk, that crosses over, because if your mom had been diagnosed with breast cancer or a sister with breast cancer and they have a BRCA, a breast cancer gene, and you have that breast cancer gene, it may increase your incidence for prostate cancer.
It's interesting. And Dr. Labrie, I don't think we've been on since my sister revealed it, but she put up a post, and Dr. Labrie, thank you so much for those that were on when I had to refer to a family member. My sister is 2 months breast cancer free. And so even more so in learning this and feeling that I'm, 10 years behind based on the latest data, I'm going to be calling my doctor and making an appointment. One of the questions that was also asked, does insurance company now see, here's a good question, Miss Teresa. Do insurance companies honor the age 40 for men, not just ones with family history, much like women's PAPs? That's a good question. Who wants to take that? Dr.
Actually,
oh, go ahead.
Go ahead. No, go ahead.
We live in a community, Massachusetts. I call Massachusetts the beta site for healthcare, because we're always in advance of the rest of the country. And no one's come to us saying that they've not been able to get a PSA exam and their insurance didn't cover it. I'm not saying that there are insurance companies that don't cover it, but I have not come across someone in our community that said that they couldn't get screened because let me be clear, starting the discussion at age 40, you may not get your PSA at age 40, but you have to begin having that discussion with your primary care doctor at age 40.
Yeah, I know same thing. I obviously order a lot of those as a primary care doctor, and I have not had any rejected. And so I don't think that's been a barrier. There is more of an institutional barrier, to tell you the truth, than there is an insurance barrier, because to order the test before the age of 45, you do have to answer a few questions and sort of say why you're doing this.
Justifying why you're doing your placing the order.
One time when it comes to sort of recommendations and equity and all of that stuff. But yes, if you qualify for it and your doctor and you agree that this is the right time to start, I have not heard it.
If you have African ancestry, and we'll leave it that way, that covers everybody. If you have African ancestry and a family history of prostate cancer, you are at high risk.
Okay. Dr. Lee, is it true? And we're talking about the PSA and basically hormones and biomarkers and whatnot. Now, I probably have an idea of what you're going to say, But is a home pregnancy test for a man, a cis man, will it indicate if you get I presume positive? Is that an indicator that you got a hormone? Because that test is usually a HCG test looking for that hormone. But we want to clarify some of the misnomers out there.
Yeah, it is not a test for prostate cancer. The screening test for prostate cancer we're talking about is prostate specific antigen, known as PSA. There is no home test for this. It's a blood test. You can't get it off of a cheek swab or urine sample or anything else. It's a blood test.
Yeah.
And a follow-up, Ma, you are really making me uncomfortable. So if someone has testicular testicular cancer and have to remove one testicle, will they still function?
They will still function. We have many men who've had testicular cancer and removal of one testicle, and still the other testicle seems to take over the function of the two major operations, which includes testosterone production. So it sort of makes up for the lost testicle, as well as sperm production for fertility.
Okay. We're down to about 5 minutes, and I do want to, in the pandemic, there was a lot of conversation about the vaccine and how it was important that Black and brown people participate in the trials. And so, Dr. Crawford, we know that research and data is hugely important. You all heard here today. Right. And so in this, Dr. Crawford, you all are doing some clinical trials, and you want to ensure that Black and brown men are part of that. How do we reach out to you if they want to be a part, or just, it is important that they participate, but we participate.
It's important because one, they can reach out to us. I would give them my telephone number, which is 202-538-3336. They can look online.
Hold on. Say that again, Dr. Crawford. 617.
No, 202.
Oh, DC. 202.
538.
3336. Let me tell you something about the Java family. A couple of these, what I call the mother's board in here, or they're going to call.
Yeah, well, call. I'm just saying, call. And then you can either go to FIN and Prostate Health Education Network, or you can go to FIN Trials, PHENTRIALS.com. And that'll take you to a website that basically each month I curate. I go through and look at all the clinical trials that are actively recruiting for prostate cancer patients. And then I put them in your diagnostic bucket. So if you are low risk, intermediate risk, high risk, metastatic, the disease that's moved to other parts of your body, there are clinical trials there. One thing to know, if you participate, NCCN guidelines clearly states that clinical trials are part of your treatment. Are treatment options that are available to you. You will get the best care in clinical trials.
Because presumably that is where the latest implementation or developments that are sort of taking place, things that are on the horizon.
Well, there's two things. One, standard of care. There's no sugar pill. Standard of care. You get the standard of care, but guess what you have? You have people that look and monitor your case all the way through. So it's concierge medicine when it comes to the treatment of prostate cancer.
And if you don't know what he meant by concierge medicine, it means that it's customized, close monitored. When you go to a hotel and you want to ask them where the restaurant is and all that other stuff, and they give you all the details and information to get what you want, that's what concierge medicine is. Whew.
Hey, can I
yes,
just say, and that's access to the newest therapies. And we talk about access, we're talking about access to the newest therapies. That's right. And I think that the other important piece here is that, here in Boston, so I work at Mass General. Unfortunately, there are insurance things that dictate, who gets to walk through these doors and such. But there are also, for the purpose of things like clinical trials, that there is access for folks whose insurance isn't necessarily taken generally at MGH, but are still have access to clinical trials at MGH and other major academic centers within the city. So I want to emphasize that as well, that if you are a patient and you have an interest in a trial, or at least hearing about a trial, that you have access throughout the city, even if your insurance doesn't dictates that your initial care is in one place.
And
that's just so important for us.
And that was what's important too. I call it like the 3 C's. It's like cutting edge technology, concierge service, and I even know no cost. It doesn't begin with the C. It's basically
but that C stands out. The no is fine in front of that C.
That's cost. And so that's and the one point I wanted to leave to is, and when it comes to prostate cancer, the amount of Black men participating in prostate cancer clinical trials is significantly low, somewhere about 4 or 5%. Groups at Harvard and colleagues at Harvard School of Public Health clearly suggest that African American or Black ancestry involvement in clinical trials need to be as high as 22%.
So if you're listening, you can't, I won't say you can't. It's interesting to judge and critique a system of which sometimes, and very valid reasons, we've all named it on here for some concerns, historical context and things, and equities, and just downright just wrong stuff that has happened. But however, like we said about the vaccine and in COVID, you got 2 Black men. One, I don't want to presume Asian Korean folks that are involved in these trials, that are clinicians, that are professors, that are researchers. And so if something goes on, they're like, wait, no, there's no equity there, or why are we doing this? So there are people that share our values and our backgrounds and our upbringing that are in these systems. And so many, as I'm saying, I know somebody's going to text me and talk about which clinical trial, I think, right now I don't need a clinical trial, but about my test and whatnot. But it is imperative that we get this information out to the community. I just want to name, and this out of all the questions and comments and everything that happened, Joseph Bennett is a young man that curates a group called Yard Time Entertainment, and he meets with young men around mental health. And I'm sure he's going to share this information with them. So we definitely, and that's there are men that fall in that 30, 40 age group that he's working with. And so I really appreciate all 3 of you being here. And Dr. Lee, your friend, is in the building. Charlotte James, she said, I'll be reaching out to have another conversation about this. And I'm sure Dr. Lee and others will be glad to come and talk more. Well, and with this, getting men into the doctor is hard. Getting them to participate in clinical trials is harder. But hopefully some clarity that we brought today will encourage men to get screened. First of all, go and see your doctor minimally, at least 1 a year. Mm-hmm. If there is something that ails you and you don't feel well, and this has been over a couple of days and headaches and stuff like that, go check out your doctor. And then in your routine and physical exam, even if you don't have your family history, talk to the aunties, talk to the uncles, and just start asking questions about family. Hey, how did Uncle Joe die? Hey, do we have any history? All this fighting we're doing in this time period around equity and improving our quality of life. What's the sense of doing that? And we're not going to be here to enjoy it.
Mm-hmm. It was really good, Jimmy. I wanted to add one more thing, is that the discussion we just had today may sound a little different when you talk to your doctors, but the discussion needs to take place. Right. That's really what I'd like to leave you with. And there are doctors out there, it's not to criticize anyone, who won't even bring up the issue of prostate cancer screening. There are people who are trained currently or in the past few years with the idea that prostate cancer is not helpful, does not help, and we shouldn't do it. They don't even offer it. So, but if you do bring it up, I assume, and I'd like to think, that most doctors will have the discussion with you and can help you decide if it's the right thing for you. But don't worry, or don't be surprised if it's not even brought up at your exam, at your routine physical. And so part of this is that we get the word out. Knowledge is power. You can then bring it and say, what about prostate cancer? And have the discussion there.
And then what we're providing is reliable information. Don't go to Dr. Google. The issue is the information that we have that we're providing to you are the information that's most current. Because we just updated our NCCN guidelines on our website. And if they say no, call us.
I was getting ready to say, this is not the opinion of none of these doctors here, MGH and da-da-da-da. But if you're going to a doctor and you attempt to have any type of conversation about a screening and they're shutting you down, you might want to consider finding another doctor. Healthcare matters. Get it and demand it where you can. Thank you all so much for tuning in to your Healthy Java today. Miss Teresa, stay off of Dr. Google there. But thank you all so much for tuning in today. Please share this not only with the man, but share this with even trans men that may just not know. And with everything else that comes with that experience, if this can be avoidable, and so it may be a hard conversation, but the reality is, genetically speaking, that is something that I wish Robbie was here, Dr. Labre, because we could have a whole session just on that. But thank you all for tuning in today. I'm going to go pay some bills and make some announcements. But I appreciate all three of you. Dr. Lee, look out for an email from Dr. James. And I think Dr. Labre, we're going to need to figure out how to, maybe this can be one of our face-to-face sort of activities and do some whatever level. Well,
wherever we can help.
I appreciate it. And I know it. I appreciate it. Thank all three of you so much for coming in today.
Thanks for having us.
Right.
Bye, Miss Charlotte.
This was one of our most informative and interactive sort of sessions with our doctors there from Massachusetts General Hospital and also Finn. Thank all of you that endured. Did I say Dr. Charlotte? Y'all know I be giving out promotions real quick. Thank all of you for tuning in today. Yeah. Being 50 years old and hearing about all this other stuff, it is quite interesting. I heard and learned about metabolic fluid and weight. This little tire I got that developed over my hips in the last 6 months. Man, in all seriousness, it's important that we take care of one another. Thank all of you that stayed. It's about 10:06. We're overtime. I appreciate you. Again, tag some men, tag some women that you know have some men in their lives that they need to encourage them to go to the doctor because they talk to y'all. So make sure they have the information. Thank you so much, Lasagna. Good to see you in the room. Good to see you in the room. And tomorrow morning at 9 a.m., Reverend Mark Scott from the Boston Public Health Commission is coming into the Java Cafe to talk about violence prevention, trauma, SSYI, the sexual healthy relationships program that he oversees. You definitely want to be in here tomorrow at 9 a.m. All right, we will see you then. Oh, of course. You don't have to give no justification or preface, nothing here, Uncle. Appreciate you and love you. All right, I'm off of here, everybody. We will see you tomorrow morning at 9 a.m. Have a great, wonderful day, and we'll talk to you soon. Peace.